I'm presenting a CW 5-month-old infant, male infant, resides in Isinya. The informant is AN, the mother. The ward is in 3B, and the date of admission was on 5th February 2023. It was 4 weeks ago. Next, please. The presenting complaints were vomiting for 3 days, diarrhea for 3 days, and hotness of body for 3 days. The patient is a referral from Mwananchi Jamii Rongai Hospital. Next slide, please. The history of presenting illness. The patient was last well. There's a typing error 4 weeks ago prior to admission when he presented with vomiting of abrupt onset, progressive in nature, non-projectile, postprandial, 4 episodes daily. Contents of the vomitor was the food ingested, white in color, consistent, was mucoid and watery, non-smelly, large volume. The mother could quantify each vomitor to be approximately equal to half 300 ml cup, associated with hiccups, belching that will resolve upon feeding. There were no exacerbating or relieving factors. There was no associated refusal to feed, no abdominal pain, abdominal distension, no hematemesis, no loss of appetite or weight loss. The patient also presented with the diarrhea of acute onset that was preceded by vomiting, regressive in nature, numerous episodes. There are 15 episodes, yellow in color, consistent, was watery and non-liquid, non-bloody, foul smelling, large volume. As a result, the mother resorted to removing the patient's diaper. No specific timing. The diarrhea was associated with hotness of body, irritability, crying, no exacerbating or relieving factors. Next slide, please. Hotness of body that was of gradual onset, low-grade fever that was intermittent in nature, generalized body associated with irritability, crying, and sweating that was localized only to the head and rigors, limited to lips, no specific timing, no exacerbating factors, but relieved by sponging and exposure of the baby by removing the clothing. There was no melena, hematochezia, constipation, no history of recent respiratory, urinary, or gastrointestinal tract infections. There were no chills, runny nose, altered level of consciousness, and convulsions. Next slide, please. Prior to admission to KNH, patient was admitted in Mwananchi Jamii Rongai Hospital on Saturday after presenting with signs of severe dehydration that included the sunken eyes, dried oral mucosa, unconsciousness, AVPU at verbal V, infusion of intravenous fluids to correct the dehydration. The following were administered: IV Ringas lactate 30 ml per kg over 1 hour, then followed by 70 ml kg over 5 hours. The IV paracetamol 100 milligrams starts. Then workups done include complete blood count, stool microscopy, the rotagen rota was detected, and abdominal ultrasound that showed there was an umbilical hernia. However, the symptoms worsened and the patient's status seemed to be deteriorating, upon which he was referred to KNH. Next slide, please. For past medical history, the index admission was at Mwananchi Jamii Rongai Hospital on 4th February 2023 for the same complaint. The second admission is currently in KNH. So there was no history of past surgeries, blood transfusion, trauma, no known food or drug allergy, no history of chronic illnesses. Next slide, please. The antenatal history. The first clinic mother attended was in Syria at the gestation age of 4 months. Concurrently, 6 visits were done. Supplements taken includes folate and iron. Vaccines were received, and tetanus toxoid, HIV, and syphilis screening were done. The mother is seronegative. The torture screening was done and was negative. There was no perinatal infections or complications. No history of drug consumption during pregnancy. Next slide, please. The birth history: the patient was born in a hospital in Isinya. Mother was 27-year-old. Patient was term, gestational age of 40 weeks. Mother didn't go into labor. Born via cesarean section that was an elective due to contracted pelvis. Was put under spinal anesthesia. The patient died immediately after birth. No postnatal complications. Discharged a week due to post-op CS, C-section monitoring and nipple extraction. Next slide, please. Nutritional history: breastfeeding was delayed and initiated in 15 hours after birth due to nipple extraction of the mother. Exclusive breastfeeding was done for 2.5 months. The age of weaning was at 3 months. Complementary feeding was initiated at 3 months due to insufficient milk production by the mother. The patient was put on infant formula such as non-milk as from 2.5 months. Food weaned on include porridge, fruits, potato. The fluid were freshly prepared, boiled, mashed, and stored appropriately. The 24-hour diet record on a typical day was breakfast porridge, the lunch was banana and mashed potatoes, supper was breast milk. The patient had a good appetite. Immunization history, all the vaccines are up to date except rotavirus was not given at 6 and 10 weeks. Next slide, please. Growth and developmental history. The gross motor, patient was able to raise the head at 45 degrees in prone position. 1 month, roll from back to side 4 months, sit without support at 4.5 months, crawl on the tummy at 5 months. Follow, okay, for the fine motor, the patient could follow moving objects by turning the face at 3 months, hold small object in the hand 3.5 months, reach out for toys at 4 months. For hearing, speech, and language, patient was able to vocalize alone or when spoken to respond by cooing or laugh at 4 months. Social, emotional, and behavioral, the smile responsively at 2 months, put food in mouth. All developmental milestones have been achieved on time. Next slide, please. Family and social history. The patient is the only child born to a single mother. No history of chronic illnesses or sudden death in the family. Parents are currently separated. Mother is 27-year-old. Mother studied till college where she attained a diploma in cosmetology in a college in Bungoma. She is currently employed by a company in Senior. Lives in a conducive environment in a 1-bedroom house that is well ventilated. The means of cooking is using a gas cooker. Eats a balanced diet and adequate meals. The source of drinking water is tap water, and there is adequate waste disposal. They live with a cousin of the mother who looks after the patient when the mother goes to work. There is no history of drug abuse, alcohol consumption, or smoking by the mother. For the systemic review, for the respiratory system, there was no cough, sputum production, coughing blood, difficulty in breathing, wheeze, chest pain.
Najma,
There were
there's nothing significant, yeah, so we can move on. Okay?
Nothing significant. Next slide, please. Okay. Before we go to the summary, were there any risk factors that predispose this particular patient to developing the complaints above? This is for the audience.
So we have a 5-month-old infant with diarrhea, vomiting, and fever for 3 days. So what Najma is asking is, from the history, are there any risk factors which may have predisposed this child?
You can comment in the chat box or unmute.
So good, I've seen, okay, excellent. So you've seen a few risk factors. Najma, I think now you can continue.
Okay, next slide, please. So for this patient, the risk factors include breastfeeding. It was delayed and initiated 15 hours after birth due to nipple retraction of the mother. There was exclusive breastfeeding was done for 2.5 months instead of 6 months. Complementary feeding was initiated at 3 months due to insufficient milk production by the mother. The patient was on infant formulas such as nanas from 2.5 months. However, the food weaned on was freshly prepared and stored appropriately. The mother also reports to have begun giving the patient tap water at 3 months. There was also use of infant feeding bottles. The age of weaning for the patient was early 3 months. There is usually a higher risk of developing gastroenteritis associated with when the complementary feeds are introduced, which is from 6 months to 11 months. But for our patients, since it was introduced at 3 months, that was a high risk of predispose the patient to developing these complaints. Immunization, the rota vaccination, it was not administered to the patient at 6 and 10 weeks. seasonality, the patient currently resides in a temperate region. For the important negative, there was no history of recent travel, no history of exposure to person with similar symptoms, no history of immunodeficiency status in the patient or the parents. Next slide, please. For the summary, I'm presenting SCW, a 5-month-old male infant who was a referral from Monanchi Jamii Rongai Hospital, who presented a 3 days history of vomiting, diarrhea, and hotness of the body that were acute onset. On examination, the patient had signs of some dehydration, including delayed return of skin pinch of 3 seconds, irritability and restlessness. Patient is currently being managed for gastroenteritis and dehydration secondary to the gastroenteritis, and is on oral paracetamol for 3 days, zinc sulfate for 4 days, oral rehydration solution, intravenous fluids, penicillin, and gentamicin for 5 days. For general examination, as an African male infant who is in fair general condition under no obvious distress, well nourished, lying on the mother's lap with cannula inserted in the left arm. For anthropometrical measures, the weight was 7.2 kg, height of 66 cm, and head circumference of 43 cm. All measurements are within normal range. Vitals, the BP is systolic of 96 and diastolic of 57 millimeters per mercury, pulse of 102 beats per minute, temperature of 36.7 degrees Celsius, respiratory rate of 3 breaths per minute, oxygen saturation of 96%. There was no scleral jaundice, there was conjunctival and palmar pallor, no central or peripheral cyanosis, no finger clubbing, no lymphadenopathy, no edema, no wasting. Features of dehydration present were skin pinch return of 3 seconds that was delayed, capillary refill time was 2 seconds, there were sunken eyes, there was no sunken eyes, the patient was irritable and restless. Next slide, please. So for head and neck, ear, nose,
Again,
and throat examination, there was nothing remarkable.
Yeah, okay, thank you. Now, can you go back to the previous slide? Okay, so who can tell me what do you think about the hydration status of this child?
Patient showed some signs of some dehydration on examination.
Okay, good. Let's move on.
Next slide, please. Next slide, please. Oh, no. Wait a minute. For systemic, okay, for the abdomen, on inspection, normal shape, no distension, scars, it's symmetrical, no visible distended veins. The abdomen moves with respiration. There's an umbilical hernia with an everted umbilicus. On palpation, there was no abnormal pigmentation. On palpation, superficial palpation, there's no tenderness, guarding, or rigidity. The abdomen is soft. Deep palpation, there are no organomegalies or masses. The umbilical hernia is reducible. On percussion, the abdomen was tympanic, no shifting dullness, no fluid thrill. On auscultation, the bowel sounds were present, no aortic or renal brewery had. Next slide, please. There was nothing remarkable. Next slide. Same here. Next. Next. So for the impression, it was gastroenteritis with some dehydration. My differential diagnosis were gastroenteritis, sepsis, and food poisoning. Next slide, please. Next. Jamal, you can actually go till the tables, the slide containing the tables. So food blood counts, it was done twice. First was done on admission, 6 February findings were the following. The white blood cell count was 13.6, which was elevated. Neutrophil 11.1, which was low. Lymphocyte was normal. Hemoglobin was slightly low at 10.1. HCG was 31.3. Mean corpuscular volume was low at 71. Mean corpuscular hemoglobin was at 22.8. Mean corpuscular hemoglobin concentration was 32.1, which was normal, and platelets of 244. The repeat was done on 9th February 2023. No, you can just go the same table, Jamal, the same table, yes. So the white blood cell counts, there's an improvement. It actually dropped to 4.7, the normal level. Neutrophil, it was still low at 1.21. Lymphocyte was normal. Hemoglobin, HCT, MCV, and MCH were still low. Mean corpuscular was normal in platelets. So there's actually a picture being shown of a hypochromic microcytic with low MCV and MCH and low hemoglobin. Next slide, please. For urea electrolyte and creatinine, sodium was within the normal range, 137.1. Potassium was slightly low at 3.46. Chloride was within the normal range, 100. Urea was low at less than 0.90. Creatinine was low at 17.2. And CRP, the acute inflammatory reactants, was actually high at 6.5. Liver function test, albumin was normal. ALP, alkaline phosphatase, was high. ALT was normal. AST was high. Gamma glutamate was high. Total and direct bilirubin were normal. Calcium was low at 2.13. CRP was still raised at 44.3. Phosphates were low at 1.63.
Okay, let's stop there. Who wants to, not you, somebody from the audience, who wants to interpret this, the LFT results? Jamal, do you want to give it a go?
I can try. So we have a liver function test here. Albumin is normal. Alkaline phosphatase is elevated. ALT is normal. AST at 63. Gamma GGT at 76, elevated. Total bilirubin is normal. The direct bilirubin is at 4, normal. Calcium at 2.13, slightly low.
So what do you think about these LFT's results?
So I'm getting okay. So the bilirubin is being normal. I know there's no obstruction, any obstructive hepatobiliary disease. The only thing that is elevated is ALP and AST. So albumin is at 40. So ALP and AST are the ones that are elevated. So there might be some liver injury, maybe.
Yeah, good. So any viral infection, and most likely, and you were told that this here, the rotavirus was positive. So any viral infection can result in your transaminases going up. And in this case, you can see that the AST is slightly high, whereas the ALT is normal. But if you look at the level, it's not more than twice the upper limit of normal. So there is a little bit of elevation. We take that into consideration, but it's unlikely to be very significant at this point in time. The gamma GT is also a little high, but it's again not twice the upper limit of normal. As you say, the bilirubin levels are normal and there's no jaundice. So that's fine. And we talked about it in the morning. Albumin levels are okay. So the liver synthetic function looks fine. I mean, we only have that, we don't have the INR. But so you have a little bit of a transaminase elevation at the AST, most likely because of the viral infection. Okay.
Mm-hmm.
Okay, let's move on.
I have a question, Dr. Laving. The ALP levels have increased by 2 folds the normal.
Yeah, but remember, this is a growing child, and many of these the references that are given for alkaline phosphatase are usually for older children and adults. In fact, many times it's just adults, because at Kenyatta and most labs don't give different ranges for different age groups. So we're still not worried about that alkaline phosphatase.
Okay.
Okay, Ayman has asked a question about the neutrophils. I think you probably made a mistake, a slight mistake. I think the neutrophils were low from the very beginning, isn't it, Najma? Was it the initial one? Was it 11 or was it 1.13? 1.3. The initial neutrophils on 6th February.
It was 11.13.
So if it's 11, then the neutrophil was actually absolute count was actually high on 6th, not low, because remember you've given the range from 2 to 7. So maybe on the initial neutrophil count was high, and then 3 days later it was actually low. So thank you for pointing that out, Ayman. Okay, let's move on.
This is an abdominal ultrasound that was done in Mwananchi Jamii. It was actually done after the patient's birth, but they said the surgical intervention will be done if the umbilical hernia there won't be regression of the symptoms. So it shows there is a strangulated. The conclusion was that it's strangulated umbilical hernia.
Okay, thank you. And I take that with a pinch of salt. In a child with diarrhea and vomiting, with fever, you have to think of most common things. However, we know that this child has an umbilical hernia. So if it is a strangulated umbilical hernia, who can tell me how would the child present with?
Abdominal pain.
True. So severe abdominal pain and bilious vomiting, right? Green vomiting. So when you have a child, infant, or neonate who presents with bilious vomiting, then you know that that's most likely a surgical emergency, and you really need to rule it out, okay, including a strangulated umbilical hernia at that point in time. This is a child who presents with diarrhea, vomiting, and fever, and rotavirus was positive anyway. So this was probably a rotavirus gastroenteritis. Okay, let's move on.
For the management, the patient in KNH was on oral rehydration solution, 75 ml per kg over 4 hours. Was given intravenous paracetamol, 108 milligrams starts, intravenous 5% ringus lactate, 500 ml in 24 hours, intravenous penicillin, 350,000 international units, 24 hourly for 5 days, intravenous gentamicin, 52 milligrams, 24 hourly for 5 days, per oral zinc sulfate, 10 milligrams, 24 hourly for 4 days, per oral paracetamol, 100 milligrams, 8 hourly for 3 days.
Okay, let's stop there. Now, somebody can someone comment about the, I don't want messages. I want someone to tell me from the very beginning, from the first one, oral rehydration, all the way down start. So tell me whether the management is appropriate or inappropriate.
It's inappropriate because...
No, who's this? Not you, Najma.
Oh.
You are the one who's present. You need to ask the audience. You need to involve the audience.
I don't.
So Jamal, please choose your friends or enemies and tell them to answer.
Oh, all right. I'm going to choose my friend Ore. Himze, you can try.
Look, I didn't get the question.
Is the management appropriate or inappropriate?
I think it's inappropriate.
You have to qualify that statement. You know, if you say inappropriate, if it's a 5-mark question, you'll get 1 mark. Now the other 4 marks, you have to give me the other 4 marks. Why? You tell me why. Come on, guys. So let's start with the oral rehydration solution. So it's 75 mils per kilo over 4 hours. Is that appropriate or inappropriate? For a child, according to Najma, it was a child with gastroenteritis and some dehydration.
That's appropriate.
Sorry? Ayman says inappropriate. What, the ORS was inappropriate? Child is vomiting. And Ayman, I said, I don't want chats. I want people to speak.
The child is vomiting, so all the ORS will be vomited and IV would be a better option.
Okay. So thank you. At least thank you for having the courage to speak up. So the management is, so for some dehydration, is that correct management, 75 mL per kilo? If you're to give ORS, it is correct, right? Over 4 hours, right? Ideally, it should be supervised. However, Ayman has a point. This child is vomiting. So if you give the ORS, the child is most likely going to keep on vomiting the ORS. But what are the guidelines? What are the Ministry of Health guidelines and the World Health Organization guidelines? The truth of the matter is the guidelines state that we must give ORS orally, okay, unless the child has severe vomiting. So if the child is vomiting, the guidelines state that we give smaller amounts more frequently. So for example, if it's 75 mils per kilo over 4 hours, and what was the weight of this child, Najma?
7.2 kgs.
Sorry?
7.2 kgs.
7.2 kilos. So 75 times 7 comes to how much? Approximately, let's say 500 mils. Yeah. So let's say again 500 mils or 4 hours. So let's say that's the bottle of Coca-Cola, the 500 ml bottle to be given over 4 hours. So that means you're supposed to, they're supposed to give small amounts more frequently if the child is vomiting. That's what the guidelines said. But in the real world, when you're out there, sometimes it's difficult. And Ayman's point therefore comes in. At that point in time, you may have to either put in a nasogastric tube and try to give it through the tube. If the child keeps on vomiting, then even in some dehydration, you are allowed to fix a line and give it IV. Okay, so good. Next, paracetamol, 108 milligrams start. Okay, so it's been probably calculated at 15 per kilo. So I guess that's okay. This is the initial management. Child probably had a fever. And then the next one is 5% Ringer's lactate, 500 mL in 24 hours. Who can tell me about that? Is it appropriate or inappropriate? Child weighs about 7 kilos. Or is your colleague going to cover that in the next presentation in the management section?
Yes, we will. We'll cover
Okay.
it.
Yeah. All right. Okay. I want one person to comment about penicillin and gentamicin. Who is brave enough to comment on that one?
I think the colleagues in. Okay, Hanif, go ahead.
I think the guidelines for antibiotics is that it should only be given once you confirm that there is dysentery or amoeba and things.
All right. And so how do you define dysentery?
Bloody stool.
Excellent. So if you see blood in stool, then you may be justified in commencing antibiotics. In this particular case, from our history that you've been provided, there was no blood in the stool. And therefore, do you think there is any indication for starting this child on penicillin and gentamicin?
None.
No, none at all, isn't it? So this is, and we discussed this in the morning with Najma, and I told her, let's present it because it's okay to present it the way it is, and then we can discuss whether it was appropriate or inappropriate. All right. Even, I mean, unless Najma made a mistake, but the dose of the penicillin also, once a day penicillin is not something that we normally give, so that's also inappropriate. So when you go out there, even when you go to the wards and look at the prescription, the treatment sheets in the wards, it's very important. In fact, start writing some of these treatment sheets, and then of course you ask the resident to countersign and to check and countersign, because otherwise, unfortunately, we all make these mistakes when you go out there. Okay, and sometimes the mistakes might not be too dangerous, but sometimes that can be fatal. So let's be careful and let's start looking at treatment sheets as well. All right, I think that's it for now. As far as this is concerned, thank you very much for a good presentation. I realized that in this this particular slide, the paracetamol has been spelled correctly, and I had a chat in the morning with Najma, so kindly requesting everyone, PCM is not a standard abbreviation for paracetamol. So please don't do these things what you see your other residents and other doctors doing. PCM is not standard abbreviation. Always use standard abbreviations. Okay, thank you.
All right. Thank you very much, Daktari, for guiding us around the history and the management. We are going to very fast go on to the discussion part, which is going to be done by our colleague Abdullahi. Abdullahi, you're ready?
Yes, I'm ready.
Okay, please, you can share your screen.
Copy share screen.
We are good. We can see your screen. You can start. Hello? Abdullahi, can you hear me? Can you all hear Abdullahi, or it's only on my side? I can't hear him.
No, we can't hear him.
We can't hear you, Abdullahi. You're muted.
Yeah. Sorry. Now you can hear me?
Yes,
Jamal,
yes.
you can hear me?
Yes.
Everybody
Yes,
can
yes.
hear me?
Yes.
Okay. Sorry. So I'm Abdullahi Mohamed, a level 5 medical student. I will take you through the case discussion. Our topic is gastroenteritis and dehydration. To be specific, our patient had some dehydration. So the above objectives will guide us through, inshallah. So first, to define what is diarrhea. In simple terms, is the passage of 3 or more loose watery stool in a 24-hour period. So, or in simple terms, you can say that more frequent passage than normal in an individual. So in infants, we to be specific, is if they experience watery high volume of more than 10 ms per kg per day in infants and children. classification. We have two broad classifications of diarrhea. We have the acute watery diarrhea, and we have the chronic diarrhea or the persistent diarrhea. Yes, yes.
1 second. So thank you.
Yes,
Please go back to the definition.
Okay.
So this is excellent. This is the way it's supposed to be, and especially the 10 meals per kilo in infants and children. And again, what you said about whatever is more frequent than normal. However, for conformity and to make everything standardized, World Health Organization guidelines state that it must be 3 or more. Okay. So I suggest for all of us, we stick to 3 or more in a 24-hour period. That's what we have defined loose stool, which is also excellent. Okay, because if someone asks you what is loose, so loose is one that takes the shape of the container. That's excellent as well. Continue, please.
Thank you so much, Doctor. So in our classification, we classify diarrhea broadly to 2 classifications. We have the acute watery diarrhea, and we have the persistent diarrhea or the chronic diarrhea. So to start on with the acute watery diarrhea, it begins acutely and it's less than 14 days. And as we said earlier, the passage of watery stool without visible blood is watery diarrhea. So just to hint, like we'll cover more the causative agent, but now to be a bit summarized, the main etiological causes of the acute watery diarrhea are the rotavirus, the enterotoxigenic, E. coli, Shigella, the Salmonella. Then now, what is the consequence of this acute watery diarrhea? Is dehydration and shock. So we also have the bloody diarrhea, the dysentery that was mentioned above just not long ago, is the presence of diarrhea with visible blood in stool. The main cause is Shigella and the subgroups. Then the others, we can have the enteroinvasive E. coli, Salmonella. The consequence of the dysentery is anorexia, the rapid weight loss, damage to the intestinal mucosa by the offensive causative organisms. To the next category is the persistent diarrhea. So now we have 2. We can be asked, what is the difference between persistent diarrhea and chronic diarrhea? So persistent diarrhea, that is diarrhea that begins acutely, but is of unusually long duration, more than 14 episodic, may present as watery diarrhea or dysentery. It's persistent. It happens more times and for a long period of time. The chronic diarrhea is recurrent also, but the difference is often due to maybe a non-infectious cause, can be a malignancy, can be other causes. We don't have a specific microbial cause that we can say it causes a persistent diarrhea, but to be on a general, like the most common is the E. coli, Shigella, but there's no single that you can pinpoint. You have the E. coli, Shigella, and the Cryptosporidium. Same, the consequences for having diarrhea for a long period of time, you will have weight loss and dehydration. So that is now the classification. And then we have another classification based on the pathogenesis, which we'll cover later on, and the mechanism of how the other diarrheas arise. We'll go to another objective is the risk factor now. The risk factor is classified broadly. We have the environmental and what surrounds the patient or the background. Basically, both of them are the causative agent are mainly through the fecal-oral route. So we have that chain which touches on the environment and behavior mostly. So we have for the young babies and children, the babies, the behavior that promotes transmission of this fecal-oral is the failure to breastfeed exclusively for the first 6 months, using of infant feeding bottles. Then when now they have reached the 6 months, when they are introduced to the complementary feeding, the food is not adequately prepared. Maybe the mother gives the food multiple times instead of freshly preparing. Maybe this time again, she keeps at room temperature. She keeps on feeding the baby the same food instead of freshly preparation. The environment also failing to dispose feces, washing of hands. So now when we look at hygiene and sanitation, we have the personal hygiene, we have the sanitation after the toilet, washing hands, and all of that. Then the other is the host factors now, which now links to direct to the baby or the patient. Now we have the age. When most diarrhea occur in children between 6 months to 11 months when they're introduced to complementary feeding. And the reasons that we gave is because of now the food they are encountering, the environment, how the food they're eating is handled and it is prepared. So age is a risk factor. Malnutrition also. Malnutrition has been found to increase the severity, duration, and risk of death when a patient who is malnourished gets diarrhea. We have also other diseases like when a child or a baby picks measles, which measles is known to cause immunological impairment. We have immunodeficiency. Maybe the child has underlying cases which have made him to be, he or she to be low in immunity, which now will have this diarrhea appearing more often. We have lack of immunization. Like in our baby, he didn't receive the rotavirus, which now led it to be a positive, to be picked out as a positive. Then etiology of diarrhea. Now, diarrhea and dehydration, maybe many people will ask, why are we linking diarrhea and dehydration? It's
Abdullahi?
because, yes.
Okay, sorry. So you can close your Twitter.
Okay, oh, sorry.
So what you just spoke, but you had not, you've not, have you put those things on the risk factors? Did you put them down, the bullets?
No.
Because you mentioned some very important things.
Yeah, not yet. I will put it after the presentation, inshallah. I realized when it's almost to present.
No problem. I mean, those are excellent risk factors that you have mentioned, apart from the ones that you have listed. So malnutrition, measles, because of immune compromised status and all that. So those are excellent. And this is a common question that is asked, okay, for you guys. What are the risk factors? So what has been listed and what Abdullahi also mentioned, those are good points to remember. Thank you.
Okay, thank you so much, Doctor. To our etiology of diarrhea, now to, like many people will ask why diarrhea and dehydration are interlinked. It has been found that diarrhea with dehydration in under 5 is a priority under the integrated disease surveillance and response strategy. It has been found that the common causes among young children in developing countries include the rotavirus, which our baby was a case. We have the enterotoxigenic E. coli, Salmonella, Shigella, Campylobacter, and Yersinia. Then we have a summarized table, which during our own time we can go through. These were pathogens frequently identified in children with acute diarrhea in developing countries, which for viruses, the most frequent is rotavirus. For bacteria, the most frequent I mentioned is the enterotoxigenic E. coli, Shigella, Salmonella. Protozoa, we have the frequent is Cryptosporidium. So
okay,
our pathogen,
again, sorry, excellent.
Yes.
So this is a very good table, and I'm happy that you have quoted a paper. But most important thing is you need to you need to quote exactly where this is from. Okay, but this is good. It's good to have data local if possible, but it's always good to quote where you pick this table from. Thank you.
Thank you so much, Doctor. So for our pathogenesis, we have two-way approach. We have the non-inflammatory diarrhea and we have the inflammatory diarrhea. So the non-inflammatory diarrhea is caused by, it happens because of, we have this bacteria, the parasite or the viruses, which adhere to our villi or to the intestine or to the, so now for the bacteria, they produce the toxin production. So now this toxin, there are two things that happen. We can have, like, for example, the toxin production can leads to increase in cyclic AMP. Cyclic AMP inhibits sodium absorption and leads to prolongation of the chloride channel, which will have more sodium and water being secreted because of the compromise in that exchanger. So we'll have electrolytes. The other thing is the destruction of the villi. We have the shortening of the villi, which now they shorten, and now we'll have a compromise in both their absorptive and the secretory is compromised. Now we'll have hypersecretion of fluid and electrolytes. That cause mostly the non-inflammatory, we have already mentioned. It's like the enterotoxigenic E. coli, which produces the toxin. We have the cryptosporidium. When we come to the inflammatory diarrhea now, and the non-inflammatory, there's no much causing of acute inflammation or like that. So the inflammatory diarrhea now, we have, from the word now, we have inflammation that's taking place. And this is because of the bacteria directly invading the intestine, which now they produce cytokines, which now triggers our immune system. Now we'll have a cascade of inflammation taking place. Cytokines, the ROS, which is oxygen species, now being produced, and the result of inflammation is tissue damage. So now we'll have damage to the intestine and the villas. Now, what is the outcome? The outcome is now we'll have leakage. We'll have this after the inflammation, necrosis, and everything. We'll have fluid and protein leakage into the intestinal lumen. So now we have things like carbohydrate, protein that's accumulating in the intestinal lumen. So now we'll have that high osmotic environment, which will now lead to more water absorption, and we'll have diarrhea. So a good example of diarrhea, that mechanism that comes through the inflammatory, is the osmotic diarrhea. And another, under the inflammatory also, we can have the infectious, the inflammatory diarrhea. So for history and clinical presentation, when we are clocking a patient who we encounter, we have history of diarrhea, what is of importance to us is we confirm, like, how is this patient really diarrhea, which is passage of more than 3 loose watery stools per day. We determine the color, volume, is it mucoid, bloody, presence of associated symptoms, vomiting, abdominal pain, fever, history of traveling, ability to feed, the urine output, maybe the kidney issues now start to come. Is the patient alert, presence of absence of convulsions, all of that. And now the risk factors that we mentioned earlier also will help us in our history. After we finish the history and everything, now we go to the physical examination. The most important thing for a patient who in diarrhea, when we are doing the examination, is we ask ourselves, is this patient qualifies to be in a state of dehydration, the signs and everything. So is the patient in shock? We have the criteria. Is he in severe dehydration, multiple, maybe 15 episodes in a day, so which can bring him to shock? We have the criteria of shock. All the 4 things, the weak absent pulse, you compare the pulses, the radial, the symmetry, the AVPU, is it less than A? You check the cold hands, the extremities, the capillary refill, as we do the Jacob and everything. Then the plus, the sunken eyes, the slow skin pitch. Now the patient qualifies to be in a shock or severe dehydration. Is he unable to drink, or AVPU at A plus sunken eyes and return of skin pitch more than 2 seconds. That is severe dehydration. As you do the exam now, we classify. Some dehydration now, in our case of our baby, are able to drink adequately, but 2 or more of sunken eyes, return of skin pitch 1 to 2 seconds, restlessness, and irritability. So in our case now, the baby had some dehydration, then no dehydration, we have diarrhea with no signs of shock, and fewer than 2 signs of dehydration. So in our physical exam, we assess the patient in all the system, and we pay attention to the aspect of dehydration. Then diagnosis and investigation. So in our main concern is, as I mentioned, shock, dehydration, electrolyte imbalance, the potassium, the sodium and everything, the chloride, then metabolic acidosis, urine output, renal impairment. Then the routine investigations were captured by Najma, the complete blood count, the electrolyte, sodium and potassium, urea and creatinine, if severe dehydration or shock, the random blood sugar, and that. Then how do you treat acute diarrhea? So the first thing is, if the patient is in dehydration, give IV fluids. After we classify shock, that we'll do the treatment of dehydration, then continued feeding, zinc supplementation, and rational use of antibiotics. So the consultant asked the doctor asked that when do we use antibiotics? So antibiotics should only be prescribed under the following circumstances: if you have suspected cholera, dysentery, diarrhea with trophozoites of giardia or E. histolytica, if the child is malnutrition, because we remember from it that we are told that if a child who have malnutrition irrespective, we give antibiotics, we assume they have infections, then underlying other illnesses requiring antibiotic treatment. Then prevention of diarrhea mostly is health education to interrupt the behaviors and the environment. So measure to interrupt transmission of pathogens, that chain. So exclusive breastfeeding for the first 6 months of life and continued breastfeeding until the age of 2 years will help in immunity and healthiness, general well-being of the baby. So exclusive breastfeeding is very important for 6 months and up to 2 years. Then appropriate complementary feeding, how the food that is being introduced, how is it prepared? Is the mother well educated? The water they are using to cook? If maybe the child is there use of feeding bottles and everything, hand hygiene we talked. Then we have the environment now, safe disposal of the fecal matter and use of improved sanitation facilities. Immunization, which we do like mass media campaign on the importance of rotavirus. Currently we have specific cholera vaccination going on. It's very important. Then measures that strengthen the host defenses. So that is for diarrhea. So to just brief for dehydration, we said how we classify the dehydration. Is it the shock, severe dehydration, some dehydration, or diarrhea with no dehydration? If the child is in shock, how do you manage? You give a bolus, ringas, 2 ml per kg bolus for the first time, 20 ml per kg bolus. Then if the baby is not able to go back to be alert, you go to then plan C part 2. That is if the first bolus has been given and we don't see any improvement. We go to plan C part 2, which now is to give IV ringas lactate 70 ml per kg for 2.5 hours if greater than 12 months, or 5 hours if it's less than a year. Then if there are any other, if you have like the child is not conscious, it's not alert, we treat for hypoglycemia, we do the random blood sugar. If maybe he came with pallor, like HB low than 5 grams, severe pallor, we transfuse. But you don't give a bolus. Maybe if it's severe first, we transfuse. Then that is for management of shock. That is severe. So for treatment of severe dehydration, which
let's just stop there.
Yes.
Okay. So let's go back to to shock.
Okay.
All right. So because this is extremely important. What's the second most common cause of death in children under the age of 5 years?
Second cause.
What's the most common cause?
Common cause, pneumonia.
Pneumonia, good. And the second most common cause is?
Diarrhea.
Diarrhea.
Dehydration.
Yeah. Okay. So I know that you have been taught these things in ITAT, but sometimes it's quite rushed in ITAT. So we need to just quickly go through this. There was a time I used to give this lecture, but then I think for whatever reason it was removed because of ITAT. So these 4 signs that all 4 that have been listed there. So when you get a child with diarrhea and vomiting, you need to assess as Abdullahi is saying, the hydration status, right? And so he talked about the initial signs and symptoms. And these are simple things for you to remember. So AVPU, so basically the level of consciousness. Okay. So when you are there and you are seeing a child who's coming diarrhea and vomiting, if the child is listless, is lethargic, in front of you or in a mother's lap or just lying there on the bed, you know that the AVPU is already less than A here, okay? And so this is a child that you need to intervene and manage quickly, because otherwise you might lose this child. Because as you talk about the second most common cause of death in is diarrheal illnesses, it's not diarrhea per se which kills our children. It's the complications of diarrhea. So it's especially severe dehydration and shock that kill our children. Okay, so you need to be able to identify shock. So if you have a listless, lethargic child, that's already a red flag. Then the next thing you do, and we have all been taught how to examine children or adults for that matter, and you do your inverted J examination, right? So when you start with the inverted J examination, you're starting with your pulse. You're starting with your hands, right? Your wrists. So if you touch the wrist, the hand of the child, and if it's cold and clammy, so that's the periphery. It's cold, you know, it's supposed to be warm. If it's cold, it tells you that there's most likely there has been significant volume loss. Okay, so after seeing the overall, I mean, you're looking at the level of consciousness, you see that this is a lethargic child. You touch the hands of the child and they are cold and clammy. So there's already one other sign for shock. And then you try to feel the pulse. Now in shock, it's difficult to feel the pulse. The truth of okay, or it's a very weak peripheral pulse. Now, for you to be able to feel that pulse in a child with shock, first and foremost, you need to learn how to feel pulses of children who are not in shock, and maybe your own pulse. I know in 4th year or 5th year medical students, sometimes you find it difficult to feel your own pulse. You might be thinking that you're all pulseless, but you are not. Okay, so it's very, very important. So level of consciousness, touch the hand of the child. If it's cold and clammy, you know that this child, we are not doing well here. Try to feel the pulse. And if you can't feel the pulse, or if it's a very weak pulse, again, that's another sign. And while you are still on the palms, now you check for your capillary refill time. So everything is done by just looking and then by just touching the hands and the palms, okay? So you look for your capillary refill time, you know how to press. You're supposed to press for about 5 seconds. You release and you count approximately. How long does it take for it to refill? And if it's more than 3 seconds, so if you've met all these criteria, now you know that this is a child in shock. And I'm saying this the third time at the risk of repeating myself, but I cannot repeat this enough, because we lose worldwide, these are worldwide statistics, we lose 500,000 children under the age of 5 years because of dehydration. 500,000 children, that's 500,000 children. Why do we lose them? It's possible that some of these children die at home. It's very possible, unfortunately. But the truth of the matter is, a lot of these children die in the hospital. And they die in the hospital because you and I failed to make the correct diagnosis. Because many times you have not examined carefully, and you don't remember that these are the signs of shock. So if you have a child who is not alert, when you feel the pulse, you can't feel the pulse. The peripheries are cold and there's a temperature gradient. What does a temperature gradient mean? That if you touch the palms, are cold, but as you move your hand across, maybe by the time you reach the elbows, you can feel some warmth. So that's a temperature gradient. And the cap refill time is prolonged, more than 3 seconds. This is a child who has shock. The other two signs, sunken eyes and slow skin pinch, are not as important. Those 4 signs are more important. So at that point in time, when you are, because you are the ones who are going to be facing this, when you go out for internship, okay, this is exactly what you'll see. So at that point in time, what do? It says here, bring us 20 mils per kilo, call us maximum 2, then plan C, part 2. Good. Now tell me, what do you do? What do you actually do? So you tell the nurse, sister, this child is in shock. Bring us please 20 mils per kilo according to the guidelines. And Say, ah, good, I've done a good job. At least I did not kill this child. If, I'm very happy. Dr. Laving will be very happy with me. True or false? You give those instructions to the sister, to the nurse, and then you move on. False. If anybody was thinking about saying true, it's false. Because you need to do something about the child yourself. So that means you need to fix a line very quickly. Now, do you think it's easy to fix an IV cannula in a child with shock who has cold peripheries? Do you think you'll be able to even feel or see those peripheral veins? Very unlikely, very difficult. So again, when we tell you in pediatrics rotation, practice on fixing lines, it's for a reason. Okay, because when you go out there, there'll be no medical officer to come and help you. And it's very unlikely there'll be a consultant to come and help you. So you need to start fixing lines now. So when you go out there, you're allowed to 3 tries. You have to try 3 times to fix a line. Okay. And in most instances, we will fail because this is a child in shock. The peripheries are extremely cold and it's difficult to fix a line. So at that point in time, what should we do? Who can tell me?
Give an interosseous IO.
Good. So an interosseous line. So getting a central line is difficult. In the past, when we were medical students, we were taught to do a saphenous cut down, which is also difficult in an emergency setting. So again, the technique of interosseous needle, that's extremely important. I think that must have been emphasized in ETAT. It's very, very important. And don't assume there'll be some fancy intra-IO needles available for you in some public hospital in Mandera. So you have to use whatever is available. Try to use a big, large bore needle, cannula. You remove the plastic sheet, and then you have to drill it in. Once you feel a give, you quickly take some specimens and you quickly fix your line there, okay? So that's step 1. You have to fix the line, and you're going to sweat fixing that line. Now, when you and let's say you're good at fixing lines, or you manage to get an intraosseous line in place. The next thing is you need to give that Ringer's lactate at 20 mils per kilo as it has been prescribed. And again, it's the truth of the matter is in our part of the world, it's us, we have to give it ourselves. Okay, so it's 20 mils per kilo. That's this child is approximately 7 kilos. So how much do we have to give? 140 mLs, right? So we have to give 140 mLs. Now, let's say it's an intraosseous, even if it's a yellow cannula that you manage to fix in a 22 or 24 gauge cannula. So if you just then ask the nurse to attach the drip and let it run, do you think it's going to run as fast as you want it to run? Because it says 20 mils per kilo bolus. What does bolus mean? Bolus means it has to run in the next 10 to 15 minutes. So if you just attach the giving set on with a drip and you say, today Dr. Laving will be very happy with me. I managed to fix an IO line and now I've attached the drip set and now I can go for a cup of tea. When you come back, or if you forget about it, let's say your shift is over, you go home, you come back and ask in the morning, what happened to the child? The child has died. Although you had done everything correct, so you thought. But the truth is that giving set is going to run extremely slowly. It's a small IV cannula, or even if it's an IO line, it's not going to run very fast. So it means that we have to give that fluid bolus ourselves. So we say 10 to 15 minutes. So if you can imagine, if you have a 10 cc syringe, you'll be lucky if you have a nurse with you. You'll be very lucky. Most times it's just you. So you take a 10 cc syringe, you withdraw 10 cc's from your 500 whatever bottle that you have of Ringer's lactate or Hartmann's. You withdraw and then you give it yourself. And it'll take you about a minute to push about 10 cc's. And remember, you have to do it, you have to give 140 mLs. So if it takes you about a minute to give 1 10 cc syringe, so how long is it going to take you? About 14, 15 minutes, isn't it? Because you have to withdraw it and you have to push it yourself. Withdraw it, push it yourself. Okay, so that's when you have given your 20 mils per kilo bolus. And at that point in time, after you have given your initial bolus, assuming you fixed your, assuming one, you diagnosed it correctly, and second, you managed to fix a line, alhamdulillah, and then third, you have to give those fluids yourself. At that point in time, after you've given that bolus, what should we do? You go for a cup of tea?
Reassess.
No, you don't go for a cup of tea. You reassess. You reassess. Good. You reassess. So how do you reassess? The same things.
Anyway,
You look at the level
Assessment
of
is the same thing from your eyes, from your fontanelle if it's a younger kid, from skin, from everything that you did in the first instance when you're assessing for presence of severe dehydration. Same thing you do again. Within a minute or so, you should be done.
Good. Not presence of severe dehydration, but presence of shock. If the shock, is the child out of shock or not? So the same things as you said. Check the level of alertness. How alert? Because in many instances, you give that initial bolus of 20 per kilo, and you will see a difference yourself. Certainly, you'll see the child looking at you. It's going to be irritable, but at least will be a bit more alert. You check the pulse or not, and are the peripheries still cold or not, and what's the cap refill time? Those are the things you're going to check. And if after the first bolus you're still in shock, all those parameters are still present, then you have to do this again, all over again. So again, you withdraw your 10 cc's and then you push it in yourself. Remember, you have to do this yourself, okay? And after the second bolus, in majority of instances, the child is out of shock because the child has had diarrhea and vomiting, so the child has quite a bit of volume loss, significant volume loss, and you have tried to at least correct that, and you will see a difference. Now, two boluses are allowed of 20 mils per kilo, and if still there is no improvement after the second one, that'll be very unfortunate. Ideally, when you have fixed your line, you should have taken some samples, and one of them should be a hemogram and group and cross match, because if the hemoglobin is less than 5, then we need blood. Now, getting blood in Kenyatta is difficult, so you can imagine getting blood somewhere in those peripheral facilities, but that's the ideal status. But in most instances, after your second bolus, this child should be out of shock. But the emphasis, my emphasis is that we cannot just write it on the treatment sheet and walk away. Okay, we have to do these things ourselves. And sometimes I know that you'll be inundated with so many patients. You'll have 15, 20 patients to clock, but you can only do one, you can only see one patient at a time. And in your triage, when you notice that this is a child with shock, you need to attend to this child first. And once the child is out of shock, then you can go and attend to other children. Okay. And you also remember the dictum in Islam: if you save one life, it's like you have saved entire humanity. So remember that. And as doctors, we have a lot of responsibility. Okay. So it looks very nice and it's easy, and these are questions that are asked as well. You might be asked this in an OSCE, you might be asked this in an MCQ. It's good to remember, but in reality, and I talk out of experience. I was an intern in Kenyatta National Hospital. I was an intern in Ward 3B, where this child is being presented. And at night, I have done this myself. I fixed an IO line and I've given fluids myself. Okay, and there was no one to help me except the mother, to helping me hold the hand, so that, because you know how difficult it is to fix those lines. So the mother was just there to hold the line to make sure the child doesn't move so I can give fluids. So please remember that. Okay, let's move on to severe dehydration.
Okay, thank you so much, Dr. Laving. So treatment of severe dehydration, we already have the criteria. So how do we go about?
Actually,
this?
can you just go to some dehydration?
Okay. Some dehydration is best treated with.
No, move the slide, but I don't want anybody to see that. Okay, that's better. Okay, now.
Okay, some dehydration is best treated with ORS. So for instance, in our baby.
No, sorry, Abdullahi, sorry. Now, I want one of you, no, don't show the slide of severe dehydration. I want someone to answer that question. I can still see the slide on severe dehydration. I don't want to see it. Okay. Now, who can answer? Ask a question. So the trick is when you're giving talks, try to make sessions interactive. Because if you just talk and the audience is just listening, after a while they'll switch off. Okay? So
yeah.
now you choose your girlfriend and tell her to answer the question. So how do you treat severe dehydration? Abdullahi, who's your girlfriend? Or you are halal?
Yeah, not yet. Not yet.
Okay. Who can answer? You guys have all seen it and should be knowing about it, but who can answer this question? How do you treat severe? Let's say you make a diagnosis of severe dehydration as per the criteria, those that were projected by Abdullahi.
Severe dehydration. It's treated in 2 steps. Step 1, you give intravenous ringus lactate, 30 ml per kg. It depends. If the patient is more than 12 months or 1 year, you give over 30 minutes. If the patient is less than 1 year, you give over 60 minutes. Then you reassess, you go to the second step, which is you give 70 ml per kg over 2.5 hours if more than 1 year, or 5 hours if less than 12 months or 1 year. Then if you give oral rehydration solution at 5 ml per kg per hour via nasogastric tube.
Excellent, thank you. That was very good. So those are important figures to remember as well for everyone. Okay, so 30 mils per kilo, and then 70 mils per kilo, and depending on the age, if it's less than 1 year, you give it for longer duration of time. More than 1 year, you'll give it at 30 minutes. Okay, so that's excellent. And if you remember the initial presentation, when Najma was presenting, that actually, from what she presented, they actually followed those guidelines. That's like severe dehydration, and they'd actually given appropriate, because this is a 5-month-old infant, so they had given 30 mils per kilo over 1 hour. Okay, so that was good. Okay, thank you. Okay, now some dehydration. Let's move on, and I think that should be the last slide.
Okay, for some okay.
I apologize. Please proceed, my brother.
Okay, thank you. So for
okay, you don't have to project, just tell us. Everybody should know about it. I think we talked about it earlier as well.
Okay. So for some dehydration, most of the use to treat it with ORS. So if it's some dehydration, ORS by mouth at 75 ml per kg over 4 hours. We continue breastfeeding and reassess after 4 hours. And then reclassify and treat accordingly. So that is for some dehydration. If the baby came with just diarrhea, but with no signs of dehydration, we give 10 ml per kg of ORS after each loose stool, continue breastfeeding, and we encourage feeding if the child is more than 6 months. That is for no dehydration. And then all cases of diarrhea, they should receive zinc supplement.
All right, that's good. Now, for some dehydration, again, when you talked about it in this child, so 75 mils per kilo, so we approximated 75 times 7 is about 500 ml. So, I mean, remember that some dehydration, you have made a diagnosis, this child, that the peripheries are warm, the pulses can be felt, okay? Skin pinch or cap refill is about maybe 2 seconds, 2 to 3 seconds. It's not severe dehydration, it's some dehydration. What happens in some dehydration, the child usually shows willingness to drink, okay? So you allow the child to drink. Now, it's easy to state and to write 75 mils per kilo. This child is fine, and you go away. Again, that's a mistake. Because remember, our parents, our mothers might not know what 75 mils per kilo means to them. Okay, so you calculate. So this is 500 mls. So you also tell them, if, for example, they have a 500 ml bottle somewhere, or tell them that this, so you can show them and tell them this amount of ORS needs to be given over 4 hours. Let's say that you see the child at 10 o'clock in the morning. So you tell them by 2 p.m., the child should have finished this much. In an ideal setting, if it's in the morning hours, then the ORS is taken within the hospital premises. So the child is somewhere, in some hospitals have an ORS rehydration room near casualty. So the mother keeps on giving, and after 3 to 4 hours, you reassess. If the child has taken that well, the child looks well, then the child can be allowed home, and you give instructions on when the child needs to come back. Okay. So again, the one thing that we have noticed is our attitudes to how we treat the mother at that point in time. Because some dehydration, we tend to dismiss, some dehydration, this child is fine. And in many instances, you feel that, oh, you have to attend to more important matters and sicker children and all that. So you don't give instructions carefully. And sometimes we are rude to our patients, or our nursing staff are rude to patients, and they tell the mother, just give this ORS and that's it, and the child is fine. So what happens is that the child may or may not take the ORS. The mother is probably unhappy about the treatment she's received and probably not willing to come back. And when they go home, the child may worsen, the diarrhea may worsen, the vomiting may worsen, and the mother tries to keep on giving the ORS and the child is not taking enough. So the next day, the child might have moved from some dehydration to severe dehydration. And if our attitudes have been bad, when we're seeing the mother might not want to come back. And then we might lose this child at home because of our attitudes. So let's be very careful there as well. So some dehydration, you explain to the mother how much, you try to give them approximates, this is what needs to be taken, and you need to tell them when they need to come back in case of danger signs. So all these are little things that are probably not there in the booklet, but these are important points that you guys need to remember. All right, thank you. Any other question, comments? No? All right, Amin, to your duas. So, Abdullahi, can you answer that question, role of zinc supplementation?
Okay. Okay, for zinc supplementation, it has been found to improve absorption of water and electrolytes. The child is diarrhea, and also it increases it has been found to have an increase of brush border enzymes. It helps to improve the functions of the brush border enzymes to do their secretory and absorptive. And so that's why we give to all patients who are experiencing diarrhea.
Yeah, good. So there's clear evidence that giving zinc actually helps in the absorption of nutrients, as Abdullahi has pointed out, also in the healing process of the mucosa as well. So if you think about it, diarrhea and vomiting has been there forever, and children unfortunately have been dying for a long time because of diarrhea and vomiting. One of the major interventions that happened was during a cholera outbreak in the 1970s, and ORS was introduced at that point in time. So oral rehydration solution, our mothers and our grandmothers, I'm sure, used to give us salt and sugar solutions, and but ORS was now specific amounts of electrolytes and specific amounts of sugar and a specified amount of water, etc. So that really changed. The number of deaths because of ORS went down by 50%. Went down by 50% by just introduction of oral rehydration solution. Think about it. So that means in the past, before that, people were giving their own concoctions, which was unfortunately not helpful. So that was one. Then the second intervention that happened is zinc. So somebody decided to do a study, found out that a lot of children, especially in the developing countries, most likely were zinc deficient, and by supplementing zinc, there was an improvement in outcome. It wasn't as a dramatic improvement as we saw for ORS when ORS was introduced, but there was a slight reduction in morbidity and mortality. So that's something that was important. And since then, there has been nothing else to kind of improve outcomes. So before ORS, we used to lose about 1 million children a year. Okay, now we are losing what, 500,000 children a year because of dehydration and diarrheal illnesses and dehydration. So we still need to look for what other simple intervention we can do, and of course, vaccinations is the next big thing. And we have those of us who've been in pediatrics for long, we have seen great improvement in the number of children who come with severe dehydration and shock because of rotavirus, which is the most common viral infection, as was pointed out by Abdullahi. Okay, so zinc was important. Was an important addition. Okay, I think. Okay, someone. Okay, so Ayman's question is: the neutrophils are high and not lymphocytes. Why do we still suspect rotavirus and not a bacterial infection? So Ayman, the neutrophils, when they go up, they usually go up in a bacterial infection, but it's not always the case. Okay, even in certain viral infections, you'll see neutrophils. And right now we have a rotavirus outbreak going on in Nairobi, rotavirus and norovirus. And in a lot of instances when blood tests have been done, I've seen quite a bit of neutrophilia, and we do not give antibiotics. We don't have to. Neutrophilia per se is not an indication for giving antibiotics. Okay, and besides, when this child came from the peripheral facility, they had done a stool test and the rotavirus was positive. So there was no, and maybe that's the reason that if the neutrophils was high, maybe that's the reason that whoever was admitting the child decided to put the child on penicillin and gentamicin, but not a strong enough indication for starting antibiotics. So the child improved most likely with just fluid therapy. Okay, and then the other question, which is out of topic, so let it remain out of topic, and we shall have another discussion someday, inshallah, after Ramadan on jaundice. I think people are tired now. We've been here for more than an hour.
Hello, doctor. Hello.
Yes, please.
There was a question I saw. A colleague was asking difference between persistent diarrhea and chronic diarrhea in terms of duration.
I thought Abdullahi answered that very well in the beginning. So the colleague maybe had stepped out. So it's there in the presentation, and Abdullahi talked about it very well.
All right, I think we've come to the end. Is there anyone who has any more burning question? Any clarification?
I have a question.
Mm-hmm.
Regarding our patients, the urine creatinine levels were actually high, and putting into consideration that maybe there'll be hypovolemia leading to AKI, in which there's supposed to be increase in creatinine and urine, but in our case, it's actually reduced. Any explanation or clarification on that, Doc?
Sorry, Najma, I didn't understand. In this patient of ours, were the urea creatinines, were they high or they were low?
Urine creatinine were actually low.
Were low, and yes. So you expect them to be high because you're suspecting acute kidney injury and pre-renal failure, isn't it?
Yes.
Yeah. So it's a good thing the child is not going to renal failure. And So one possibility is that the child was actually, the mother was actually giving fluids during the course of the illness. And then remember when they went to that peripheral facility, and from what you were telling us, the child was actually appropriately managed, was given 30 mils per kilo 1 hour, and then 70 mils per kilo over 5 hours before the child was actually referred to Kenyatta Hospital. So I think the child got adequate amount of fluid, and this prevented the child from getting into renal failure, which is a good thing, because renal failure is not a, we see poorer outcomes when children come with severe dehydration and acute kidney injury. The outcomes are much poorer. Okay. And remember one thing always, so that you should always treat the child. Do not treat the laboratory results. So for example, if you get this child and the WBC is high and the neutrophils are high, but it looks like a viral infection, treat as a viral infection. You can always repeat the hemogram the next day. And if it's still high and your CRPs are really high, then you can say, okay, I can start an antibiotic at that point in time. If you have done, you've taken a blood sample in this child and the potassium comes back as 6 in a child who's having diarrhea and vomiting, and you know that they're supposed to be losing potassium when they have diarrhea and vomiting, and yet the sample says 6. So don't start giving insulin and whatever to try and correct the potassium. The ideal thing to do, if you can, is to repeat your potassium immediately. Take a blood sample and take it to ICU, whatever it is, and get your potassium. If the potassium is still high, then you need to correct the potassium. The chances are that there might have been a hemolyzed sample and the potassium was a bit high. Similarly with your urea creatinine. If you do one specimen and clinically it doesn't fit, so don't treat the lab result. Look at the clinical picture. You have the patient in front of you, and then you make a decision whether you should go ahead and do something about those results, or would you rather repeat the results if possible? So make the decision at that point in time.
Okay.
I neither have a question. I don't have a question, but I do have a comment. Yes, well, my name is F. Golawis. I'm not an sound member, but I've often come to the sound invitations for their presentations. And being a medical student myself, I couldn't help but notice that I've heard great things about you, Dr. Laving. And I must say that this evening, it was quite a joyful pleasure to listen to your insights about management of shock and diarrheal diseases. And I think it's a big blessing to have a mind like yours impacting on minds like ours in this present time. So mine is just to express that pleasure and to applaud the presenters and everybody, and for allowing me to have space to listen and learn and to be a better physician in the future. So much appreciated to everybody, and to you especially, sir.
Okay, thank you. You're most welcome. I hope you'll always come to the sound, not only the CMEs, but come to the sound functions as well. And who is Jamal? Make sure that you invite him to the sound medical camps as well.
Inshallah. I know.
Great. Good stuff. Much obliged, sir. Much obliged.
Okay.
Evergo is a good brethren, is a good man. Inshallah, very good colleague, quite friendly. Welcome, Evgo, and inshallah, we're even hoping to open the platform to the larger medical school very soon. I think we've come to the conclusion. This was a very lengthy discussion, full of a lot of knowledge and insights from our very own Dr. Laving. I want to thank you very, very, very much for, first of all, responding to our short notice and making time out of your very busy schedule up to this late hour. We don't take it for granted. Yeah, I know it's quite a sacrifice to come to the ground at such a time and to stay this long and to answer all our questions. I want to really thank you so much, inshallah. We appreciate all your guidance, and inshallah we shall keep engaging you for more. To our presenters, Najma and Abdullahi, you've done quite a good job in preparing. Some of these things, they take time. You have to go to the wards, come back, make slides and all that, yeah? So we really want to thank you so much for keeping the program lively and all our participants and for the engagements. Thank you so much for making this a success. With that, I want to wish you all well. Very lovely night, inshallah. Have a good night. Thank you so much.